Hello, thank you everyone for joining us today. I have no idea how many people are in the meeting, and that's probably a good thing. So I'm just going to pretend that it's me and Alex having a little chat about the practicalities in DOAC selection. My name is Becs Walsh. I'm the lead pharmacist for thrombosis and anticoagulation at Sheffield Teaching Hospitals. Alex and I are here today on behalf of the VSN, which is the VTE Specialist Network. That is a network of allied health professionals involved in the care of patients with or at risk of thrombosis. So we are here representing them. More about that network later. I'm sure some of you are members, but I'll let Alex introduce herself before we get going with the slides.
I'm Alex. I'm the VTE Prevention Clinical Nurse Specialist at George Eliot Hospital in Nuneaton, and I'm also the Digital Secretary for the VSN.
Thank you. So this session is going to hopefully be an interactive one. I realise that people are a bit limited by the way the tech's set up, but so please make use of the chat function. Alex is going to be monitoring the chat, and yeah, please use it. There's a Q&A facility as well. We'll probably look at that at the end of the session, but keep questions coming in and thoughts, and because there'll be an opportunity to sort of interact with the presentation, and we're very hopeful that some of you might want to do that, otherwise it'll be a bit dull. So the aim of the session is to identify issues that might need to be considered when selecting a DOAC. So some of the things that might not be considered in the first instance, some of the sort of the less usual considerations. We'll unpack those a little bit more to explore the options for DOAC selection on the basis of these considerations, and hopefully facilitate discussion between us attendees and share our experience. There will be an opportunity for the roundtable discussion will be shortly after this session. So there's more opportunity to do that. And also the speakers from the previous session, I don't know if some of you will have attended that, will be at the roundtable discussion. So hopefully a chance to ask questions about all sorts of elements of DOAC use. But just to say that this session we'll be talking about DOACs for VTE and not AF. And actually VTE treatment, not VTE prevention. So that's the caveat, is that everything you hear today from this session relates to DOAC use for VTE and not for AF. There is some overlap, but we won't be considering AF today. So these are the sorts of issues that we'll be discussing, and as we go through, we'll sort of tick them off, and whatever we don't cover in the case studies that we present, we'll come back to at the end. So some obvious ones: contraindications, co-prescribed meds, some of the big hitters, renal function, extremes of body weight, some of the things that are common issues with, well-known issues with the DOACs, a little bit about some of the other issues too. So we're going to go through a number of case studies. Obviously, case studies are made up, but supposedly based on truth. So these are patients that we've designed to illustrate the point. If there are any mistakes in any of these case studies, that's not deliberate, but please point them out because they'll be helpful for future talks. So case one is Mr. JB, a 79-year-old gentleman who presented to the emergency department with chest pain and hemoptysis. Past medical history of hypothyroid, COPD, and a previous GI bleed in 2018. CTPA demonstrates a left pulmonary embolism, and there are some pertinent factors about this chap. He's 55 kilograms, his creatinine clearance is 29 mils per minute. His full blood count and his LFTs are normal. So, question for the room. What are the therapeutic options for this gentleman? Which would you choose and why in the first instance? So have a think and tell us in the chat what you would do for this chap. Hopefully people are deciding to anticoagulate him.
So the first one I've got is low molecular weight heparin. And someone else said start treatment dose, low molecular weight heparin. We've got DOAC, we've got RIV for 3 weeks, and then 15 milligrams after that, once daily. We've got 5 days of low molecular weight heparin and a doxaban 30 milligrams once daily after that. Again, DOAC, apixaban, DOAC, low molecular weight heparin, then DOACs. Warfarin is my first option due to the low EGFR and the history of the GI bleed. So there we go.
Great, thanks. That's everything covered, I think. Brilliant, thank you. Well, yes, there are lots of options for this chap. We have not included warfarin because this is a talk about DOACs, but that's not to say that it's not an option. So let me unpack the DOAC options for this chap. So yes, in no particular order, edoxaban preceded by 5 days of low molecular weight heparin, which might be a bit of a challenge if your patient's on an ambulatory pathway, not impossible, but may mean that it's not the first line. Rivaroxaban, 15 milligrams twice a day for 21 days. Now, I haven't talked about doses yet, but we'll come back to doses or doses outside the initial sort of run-in period. Apixaban, 10 milligrams twice a day for 7 days. Dabigatran is not an option. Don't know if anybody said dabigatran because the creatinine clearance is less than 30. Okay, so if you were going to prescribe this gentleman edoxaban after the 5 days of low molecular weight heparin, what dose would you use and why?
So I've got a 30. 30.
Another, yeah.
Somebody mentioned 30 earlier on.
Yeah,
30. Someone's given 30 and the reasons why they would prescribe 30.
which were weight less than 60, I think I saw.
And a creatinine clearance of 29.
Yeah.
And again, body weight, weight less than 60, creatinine clearance.
Yeah.
So
yeah. Good. That's what we thought too. That seems sensible. That's within the license for VTE for edoxaban as well. Thank you. Would anybody, if the people who were going to go with rivaroxaban, what dose would you use after the initial kind of run-in period?
So someone in the original answer said 15 BD followed by 15 once daily after that. And we're getting 15 milligrams so far.
Yeah, I think I'd do the same. 15 milligrams twice a day for 21 days, then once daily at 15 milligrams because of renal impairment and the increased bleeding risk. Would you co-prescribe anything else? Anyone?
PPI.
Thank you. Yeah.
Yeah, PPI.
Yeah, on the basis of past medical history of GORD. Yeah, great. Any apixaban voters in the room? What would you dose after the initial 10 milligrams BD for 7 days and why?
So we have 2.5 milligrams BD.
Yeah.
Grams BD. 5s.
Yeah. Yeah, so the dose now I learned lots of new things preparing this presentation, okay? And one of the reminders I had whilst prepping was about the reduced dose of apixaban, which is only recommended for SPAF, so not for VTE. And I don't know how many times I will have perhaps failed to notice that when somebody was asking me a question about apixaban dosing, I gave them the answer based on the SPAF dose recommendation, not the VTE recommendation. So I therefore would not reduce to 2.5 BD in this instance. You could note that the use of apixaban is recommended with caution in patients with creatinine clearance less than 30 mL per minute. But on the basis of the recommended dosing of apixaban, I wouldn't be reducing it to 2.5 BD. Does anybody want to come back with a question or a comment or that's a disgrace, any comment like that in the chat? People are happy with that rationale? Silence from the chat, so I think I'm safe. Excellent, thank you. Yeah, thank you.
So yeah, tolerated the loading dose without bleeding. Yes, they would give, I'm presuming they've just written yes, so I would say yes, they would give 5 milligrams twice daily.
Let's assume that too. Great. Dabigatran, not an option because the creatinine clearance is less than 30. We're not big users of dabigatran, and I don't wish to understate that, but I don't have a huge amount of experience with dabigatran. So if there are people in the meeting who have more familiarity with dabigatran, do chip in and ask away or share your experience.
So there's a couple of extra comments that have come in. It says use of river with creatinine clearance 29 is also with caution.
Yes, thank you, it is, yeah.
But that's also one of the reasons why we talked about using the PPI cover as well, wasn't it, Bex?
Yeah.
So that we're doubling up with everything there. Previous talk mentioned option to do low molecular weight heparin for 7 days, then go to usual dose of apixaban in renal impairment and low body weight.
Yes, I mean, he's not on the what I would consider low body weight. 55 kilograms, don't get me wrong, it's not obese, but he's not at the worrying end of the body weight extreme. So, but yes, I was at the previous talk and that was discussed for particularly for low body weight, poor renal function patients, that was considered a good option. And, you know, there's lots of options. That's why we're talking them through. And there may be pitfalls that with anyone. So yeah, good. Thank you. Good to discuss. We haven't talked about lactose intolerance, but there's something in. Was there something in the chat about a lactose?
There's someone's putting here that dabigatran is the only lactose-free DOAC. It's not the lactose-free DOAC. No. The doxaban is your lactose-free DOAC.
Yes.
There's some people writing things about what they do for apixaban after 6 months when they reduce it down to 2.5.
Yeah.
And it says someone else has also written reduction of dose of apixaban is not that clear on patients with VTE.
Yeah. Yes. In the sort of acute setting, again, we haven't touched on the long-term prophylaxis or the secondary prevention dosing, but yes, that's a good opportunity to reduce the dose. Yeah, I mean, the renal, we'll talk a bit more about renal impairment and how suggestions for managing patients with renal impairment towards the end of the talk. I'd also refer you to the previous talk by Raza and Tristan, who talked a lot about renal impairment and a lot about DOACs in extremes of body weight. I don't want to risk contradicting anything that they said, so we'll look briefly at those issues later on through the talk. Okay, good, let's move on. beginning to realise the pitfalls of making up cases. So this 50-year-old lady presented to the emergency department with unilateral pain in her right leg, redness and swelling. She had gastric sleeve surgery the previous week, and she was at the time of presentation on extended prophylaxis post-operatively. We use low molecular weight heparin, I think most places do. She had a past medical history of obesity, hypertension and type 2 diabetes. So a Doppler demonstrated a right leg DVT. Again, there are her sort of relevant particulars. She's 148 kilograms, creatinine clearance is 110 mils per minute, and her full blood count and LFTs were normal. So, same question. What are the therapeutic options for this lady? Which would you choose and why? Bear in mind that we've been learning a lot from TikTok, haven't we, Alex, about gastric surgery and the realities of life beyond it. Her medication will need to be crushed for the first month post-op.
So we've got enoxaparin or apixaban. Hang on, we had a lot of flipping then.
We did, didn't we?
So low molecular weight heparin for 4 weeks, then can switch to a DOAC, but would need trough and peak levels. Riv, apixaban, not Riv, as affected by meals. Apixaban, rivaroxaban, low molecular weight heparin, then Riv, apixaban. In our trust, we still tend to use warfarin if the body weight is greater than 120 kilos.
Okay, yeah, good.
Levels are coming up quite frequently as well, whichever DOAC you use. Yeah. So
let me show you the next slide, which is a bit fuzzy, isn't it? But that's from the ISTH recommendation on the use of DOACs in patients with obesity for treatment and prevention of VTE from 2021. So that's their recommendation in terms of site of absorption of the different drugs and which one is most appropriate. So it seems like on the basis of this recommendation, apixaban is the most sensible. However, share your concerns about using DOACs in the immediate post-op period for somebody who's just had bariatric surgery. So yes, might think about using low molecular weight heparin for the first month post-op and then apixaban. Apixaban because of that table and what that suggests, but also, again, we'll look at it a little bit later on, use data in extremes of body weight. Yes, the discussion about levels in the previous talk was interesting, I thought, because really we're looking at accumulation versus therapeutic benefit, aren't we, in the extremes of body weight? So somebody, we want a trough level in somebody who's obese because we want to make sure that they're not clearing it too fast. Okie dokie.
Previous talk specifically mentioned evidence supporting rivaroxaban in bariatric surgery.
Yes, it did. That is tricky when you look at the sites of absorption. I know there was some chat in the previous talk about food and whether rivaroxaban, you say to somebody who's just had gastric surgery, right, you need to take this medicine with a high fat, high calorie meal. Is that reasonable? Is that fair? Is that just silly? So I know there was some chat about that as well. I think it's difficult on the basis of this table to suggest that rivaroxaban would be first line, but I'm happy to be corrected in the roundtable discussion or on the basis of levels. I mean, you know, we do have levels, the ability, most of us, to measure levels, and therefore we have some assurance what do levels mean. That's a different question, but we do have some assurance about monitoring levels. So rivaroxaban, certainly there's more data about that in the obese population than any of the other DOACs. It's not a terrible option. I think you'd need to consider whether it was being absorbed. Nobody said edoxaban, did they? Was it just apixaban and riv and low molecular weight heparin? Yeah. And dabigatran, you can't open the capsule. And edoxaban, not much evidence for use in patients with obesity. Also, this lady had a high clearance, creatinine clearance. Again, we'll talk about that in a little while. Okay, let's move on. To this gentleman, 64-year-old, 3-day history of dry cough, sudden onset chest pain. CTPA shows a bilateral PE with right heart strain. Past medical history of lung cancer and hypertension. So multiple meds for his hypertension and his cancer symptoms. He uses a compliance aid to support the use of his medications. He's 62 kilograms and has been losing weight recently due to poor appetite. His creatinine clearance is good. His full blood count and his LFTs are normal. I think you know my next question. What are the therapeutic options for this chap, and which would you choose and why?
So we have PESI score is high, so preferably admit. Low molecular weight heparin for 5 days, then apixaban. Low molecular weight heparin followed by a DOAC. Low molecular weight heparin or apixaban. Low molecular weight heparin until consulted with hematology. Apixaban if no interaction with other meds such as chemo. Rivaroxaban after a lead-in with low molecular weight heparin. Depends if he's on SAT, as he may be drug-drug interactions to consider.
Yeah, so, good.
Yeah.
Interesting that you've nearly all gone with a low molecular weight heparin lead-in. Interesting. Thank you. I mean, you need it for edoxaban, but not many were prepared to go straight to a Pix or River. I didn't think River was a brilliant option for him because of his poor appetite. So again, we'll talk a little bit about the recommendations for taking rivaroxaban with food, but I wondered whether that was perhaps not a great option for him. Nobody said dabigatran. No evidence for use in cancer-associated thrombosis with dabigatran, so I wouldn't recommend that one either. Yes, I suppose bilateral PE, you might think, all right, let's get a low molecular weight heparin in for a little while, especially if he's an inpatient with a high PESI score. Might seem reasonable to give him 5, 7, 10, 21 days of low molecular weight heparin and then switch to a DOAC. I couldn't see a reason for a dose reduction, so I went with full dose DOAC. Does anybody disagree? Would anybody like to reduce the dose of the DOAC if they selected that? Thank you, Jan.
Everyone's saying.
Oh, excellent. Good. Just had a horrible feeling I'd missed something. Great. Yes, you're right to consider systemic anti-cancer therapy. The other consideration when it comes to managing patients with cancer-associated thrombosis is the site of their cancer. Now, there is a talk tomorrow which includes cancer-associated thrombosis. I'm not going to go hugely into the whys and wherefores and the particulars, but I'm sure you're all aware that they're not recommended for use in patients with luminal cancers. This chap doesn't have a luminal cancer, but that would be something to consider if you were being asked to make a recommendation or you're trying to decide on a therapeutic option for somebody with cancer-associated thrombosis. The bleeding risk that cancer presents, as well as anticoagulation presents, it can be a very delicate balance, particularly, I guess, if there are periodically interacting medicines that, such as sort of pulsed chemo, that might drive the platelets down, that might increase or reduce the level of therapeutic anticoagulation. So lots of things to consider. Did we talk about compliance aids? Have we talked about compliance aids?
No, no one's mentioned them.
No. Compliance aid wise, again, dabigatran's not suitable to go into a compliance aid, but the others are, as far as I'm aware. Certainly we would put them into a compliance aid. So it's another way of narrowing your options, I guess, if you're looking for a way to do that. Update hot off the press last month, I think, from the British Society of Haematology, an update on the management of cancer-associated thrombosis. We like infographics. You'll notice in the reference, in the references, quite a helpful infographic on guidance in choosing an anticoagulant in patients with CAT.
Just one comment here, Bex. Eileen has said that finding resistance to using DOACs in patients with cancer, mainly around the reversal of the patient bleeds. So many consultants still wish to use low molecular weight heparin.
Okay. Yes. I think we are certainly still being met with surprise by certain people when we suggested DOAC in patients with cancer, because low molecular weight heparin has been the mainstay for such a long time. But there is a small but growing evidence base for their use. We will talk about that later on, and I will direct you to some useful references, which I hope will help. I suspect it could be that there's not as much evidence as we think if we're using cancer patients, but we're quite keen to use them. That might be a position, and real world data or clinical experience sort of locally may not necessarily be underpinned by published data, but we'll have a look at some of that later. So maybe there's your colleagues are right to be cautious. I think when you're considering whether to give somebody an injection every day versus a tablet every day, it seems more reasonable to offer them a tablet perhaps. But patients are surprising, and what we think they care about is not necessarily what they care more about. So yes, hopefully. And as part of the roundtable discussions, Raza Alican, who's one of the authors of this guideline, is going to be part of the roundtable discussions. Save your questions for him, he'll know what to say. Right, finally, case 4. Miss YL, a young lady, 24-year-old, 2-day history of left leg pain, redness and swelling. She presented to the GP, who referred her to the emergency department, where she was diagnosed with a left leg DVT. Past medical history, combined use of the oral contraceptive pill, but nothing else. Weight 52 kilograms, creatinine clearance good, 89 mils per minute, normal LFTs and full blood count. So what would you give her and why? Our buds have all gone to sleep.
Here we go. Apixaban, switch to POP or other depot. Any DOAC, switch to progesterone only pill. can have a DOAC, counsel about pregnancy, Apixaban, any DOAC, she should stop using the OCP, any other alternative. Apixaban, RIV, daily dosing with a progesterone only pill, any DOAC. Apixaban, no need to stop the pill immediately, refer to GP to consider alternative contraception. Apixaban, caution with menorrhagia, patient preference read once daily or twice daily.
Yeah.
Switch contraceptive, pregnancy counselling, check for eating disorder, then avoid RIV.
Okay. Interesting. Thank you for taking part. So I got, in theory, any of the DOACs are an option for this lady. The results of the period study, which was published by Jigs Patel from King's, he's speaking this afternoon if you wish to know more about this study. Very interesting look at the effect of anticoagulants on heavy menstrual bleeding and in particular quality of life associated with that. His study suggested that the twice daily DOACs are associated with fewer incidences of heavy menstrual bleeding than the once daily preparations, although if you put someone on an anticoagulant, they will bleed more, whatever the circumstances. So on that basis, I went with Apixaban or dabigatran. Now, again, like I said, we haven't got a huge amount of clinical experience of using dabigatran for VTE treatment, but that might be an option for this lady. And then in terms of her use of the combined oral pill, I think our practice would be to keep her on it while she was on therapeutic anticoagulation. And should she stop anticoagulation in the future, to suggest she switches to a progesterone-only preparation. Now, obviously, that is a little bit freaky when you're a pharmacist and you look at the contraindications to use the combined pill, and the first one is active or previous history of venous thromboembolism. But actually, I understand the rationale a bit better now for that advice. Withdrawing the oral contraceptive pill could contribute to menorrhagia, which is not something you want to do in somebody who's newly anticoagulated. And it seems that that's a sensible way forward, just temporarily while she's on therapeutic anticoagulation. Alex, is that your experience? Is that your practice? Yeah, thank you. Anybody else doing that, or is that just a little bit too far outside the box for many? I mean, my colleagues take some convincing when they say, what? Oh, you're muted, Alex.
Sorry, I've got a lot of noise out the back here. It is something that we do fight a lot with. If people ring for advice and they say that they've got a young person on the combined pill, we say keep the pill going while they're on therapeutic anticoagulation, and we'll review it, you know, in clinic, or we'll contact them and have a chat with them about what to do with their contraception going forward. Yeah. And again, it's the same. Are you sure? You know, we think this has caused the clot, but yeah.
Yes, thank you. Interesting. One of the chatters has fed back about using dabigatran in some patients, with a discrete group of patients with some success. So that's good to know. Thank you for sharing that. So those are the end. That's the end of the case studies. This is the list that we started with, and I think the things in red we have more or less covered. There's probably more to say about most of them, but we've addressed some of the issues. We've looked a little bit at renal function and a little bit at extremes of body weight, but we'll cover that a little bit more in the next few slides. So I often get asked about liver impairment and when is it safe to use a DOAC. So according to the SPCs, when the AST or the ALT are greater than twice the upper limit of normal, or I think in the case of apixaban, the bilirubin is 1.5 times the upper limit of normal, they are not recommended. We used to see sometimes a transient rise in the transaminases post-COVID infection. And so in somebody with a COVID-associated clot and a transient rise in transaminases, then it may be something that you could consider. I certainly wouldn't be too worried about a transient rise. I think where the liver function tests are limited is in giving you a sense of how the liver is functioning. So certainly locally, we look at bilirubin and we look at albumin and we look at platelets, and we try and zoom out a little bit to assess the function of the liver rather than just what the liver function tests are saying. They are tricky. The rivaroxaban SPC mentions the Child-Pugh score. Have a look at the SPCs, but basically none of them are recommended in those circumstances. Again, if anybody's got any experience of using DOACs in patients with within those clinical parameters, so elevated AST, ALT, or bilirubin, do share it with the chat. And the context as well, that's helpful. Now, even I think since I've written this slide, things have changed in terms of the cost of DOACs, because there's some suggestion that rivaroxaban is available generically. We certainly are seeing the cost of apixaban significantly reduced since the unfortunate for BMS court ruling, which invalidated the patent. So apixaban, ding ding, first line, all change, first line for everything where DOAC is indicated on the basis of cost, where all things are equal. For our clinicians, particularly the non-hematologists, that's not a very hard sell. They were quite pleased, thank you, to be asked to prescribe apixaban first line for AF. So everybody's happy, apart from the patients that were switched to edoxaban under the last cost-saving initiative and the practice pharmacists who are trying to manage those patients. I'm not sure about River. You guys might know more about me than whether rivaroxaban is truly off patent and available cheap. I'm not aware that it is, but when I looked on the SPC, the EMC this morning, there were loads of different products available. So maybe you're going to tell me something I don't know yet. Reversibility, we've already touched on it a little bit, can be an issue. I think more so with patients when we were switching patients from warfarin, because at that point we didn't have a huge amount of experience with the DOACs, and there was a known reversal agent for warfarin. We basically had a well-established pathway for managing patients who were over anticoagulated with warfarin. There is a reversal agent available for apixaban and rivaroxaban in England and Wales. NICE have considered its use and recommended it, but only for GI bleeds. In Scotland, SIGN have said something slightly different. So you'll know wherever you practice, you'll know what the position is. We are using andexanet alpha, and I think there's a roundtable or a symposium on andexanet alpha as part of the setup here. So if you're unfamiliar with that, do catch up on the recordings with that. We've talked a bit about monitoring and availability and limitations and peaks and troughs, and does everywhere do monitoring? What are we monitoring for? I think we're really fortunate to be able to access labs that can do monitoring of these still relatively new drugs. So yes, they can all be, we can assay for all of those, all of the DOACs. Now, this issue about food and river, what's people's experience in clinical practice? Have people seen patients clot on river because they haven't been taking it with food? Is that real out there? Certainly the recommendation is to take with food. Thank you, Ronwyn, thank you. Especially after a high fat, high calorie meal. So certainly my advice would be to take with the main meal of the day. Again, traditionally we went with 6 o'clock for administering rivaroxaban, I think, because that's when we used to give warfarin, but patients can take it whenever they want, as long as it's the same time every day.
So we've got yes, propagation following not eating enough with 15 milligrams twice daily. It might help with compliance.
What might help with compliance? Which element? Once daily. Once daily medications are generally taken more regularly than multiple administration times. I guess the downside of that is if you miss a dose of river, it's a long time to wait until your next dose accidentally. Whereas with a BD prep, you might have.
So someone said here, I've heard, but the querying the source anecdotally, that a glass of full fat milk is enough calorie content. We did a bit of digging around, didn't we, Becs? And we found one recommendation was that it should be around about 500 calories is sufficient. So again, we don't know. As we said, we did a lot of digging. We only found one that specifically mentioned the number of calories, but
yeah,
we normally advise main meal of the day. Yeah. So someone's asking about DOACs, how often should they be monitored and what parameters? DOACs shouldn't be monitored at all. So unless you're worried about extremes of body weight and
accumulation, toxicity.
Accumulation with renal impairment, but your parameters are set by your labs. Anecdotally, consultants have said we have levels, but we don't know what those levels show us. So it would be down to your individual labs and consultants to say what the levels mean and what they would expect.
Thank you. I'm going to whiz on because there's 1 minute left and I've got about half a dozen slides. And you might have questions, so we want to be able to address those. Going back to contraindications, for most people, they know this. I think it's worth spelling out that pregnancy, breastfeeding, mechanical valves are contraindications to DOAC use. Okay. There are other options that need to be considered for this patient group. Yes, warfarin, not in pregnancy, but in breastfeeding is suitable and would be the default anticoagulant for most of those other indications. Although pregnancy is not an indication, is it, for warfarin? Again, I'm not going to cover everything on one slide. Please note this is not an exhaustive list of interacting co-prescribed medication, but these are the sort of the big hitters in terms of effects on DOACs, and also the usual, the kind of ones that crop up usually. Most of the azole antifungals are contraindicated with all of the DOACs. Some of these medicines are contraindicated with some, but not others. You might find, for example, that edoxaban gives you fewer interactions or fewer reasons to be concerned about interactions, but that is by no means a blanket approach. Please don't consider this as the definitive guide to interactions with DOACs. Extremes of body weight, we've touched on, haven't we? And I bet you've all got some lovely clinical experience of using DOACs in patients at extremes of body weight, because patients are getting bigger and smaller patients are more frequently needing DOACs. So actually our practice is varying more widely. Bear in mind that less than 5% of trial patients in the apixaban and the Einstein trials were over 120 kilograms. So trial data is limited in patients with obesity. Again, Tristan just presented some really interesting information about their practice and what they found locally. They have some concerns about patients who are over 160, 170 kilograms, according to their local practice. Ask him about that in the roundtable discussion if you weren't able to attend his talk. And similarly, very little phase 3 or real world data in patients who weigh less than 50 kilograms. Now, we would use the doxaban in tiny, frail people. I wonder what your practice is. Is there one that you prefer? When do you avoid? What are your experiences with using the DOACs in either end of the weight spectrum? Again, there is a very helpful reference here, which is where some of the illustrations come from on the next few slides. Vicky Speed has done an illustrated guide to using the DOACs in extremes of body weight, liver impairment, and renal impairment. So I would encourage you to look at that reference for more information. Renal impairment, this is just a summary of the information that was put together in the drug safety update about dosing properly in renal impairment. I think I read somewhere that 30% of patients are on the wrong dose for their renal function. So not all of those were overdosed. So it's quite interesting to know that patients might be being underdosed in that group, in that at-risk group as well. Again, Vicky's reference really helpfully summarizes the evidence that she and her team have found on the use of DOACs in renal and liver impairment. And yeah, your practice might be similar. First line should read less than. I don't know what that means. Okay. And finally, remember them, patients. We did all really to consider their preferences. We've just whizzed through some of the things that we think are important. It's important to ask them what they consider important. Is reversibility something that they're anxious about? Is their lifestyle conducive to having their main meal at the same time every day? Do they need a compliance aid? Have they got a feeding tube? Yada yada, all the rest of it. I think sometimes, and I don't know if your clinicians do this, but even our specialist clinicians go in with a recommendation for a specific drug. And we need to be asking patients more about what they want. It's time, it takes time, doesn't it? It's time consuming to have a conversation with the patient about their preference versus making a decision on the basis of a conversation with them. So in terms of useful resources, SPCs can be helpful. Interactions checker like the BNF and Stockley's drug interactions checker, which you might need to access via your medicines information department. The VSN is full of people with real life experience on using DOACs. on thromboprophylaxis, on challenges from patient safety changes. If any of those things are things that you're interested in, or you're dealing with issues that you're dealing with, do consider joining the VSN if you're not a member. And you have access to 70 odd other brains and clinical experience, and no question is too dim. So there's a shameless plug for the VSN. And then these, I have deliberately included the full links because you probably won't have electronic access to these slides. Some useful reviews with pictures, because we like pictures. And one about bariatric surgery and sites of absorption as well. Thank you. I'm sorry we've overrun a tiny bit and you've all gone quiet, so I hope that you're still there. How can we help answer questions?
There is one question in the chat box, Becs, about VTE recurrence. Is this the contraindication for DOAC use? Can an alternative DOAC be tried following a period of low molecular weight heparin?
Love that question. Answer depends on the circumstances, I would think. Recurrence in somebody where concordance might be an issue, you could do some delving, couldn't you, and find out whether they've been taking it according to the instructions or not. I think if you're convinced that somebody's been taking a DOAC according to the instructions and they've still developed a clot, you ought not to be considering a new DOAC. You ought to be considering low molecular weight heparin and then warfarin. But these things are on a case-by-case basis. What do you think, Alex?
I would say, so previous experience has been that we say that it's a class effect, and so so long as they've been compliant and everything has been right and it's the right dose, then we would switch them to low molecular weight heparin and then to warfarin with a higher target range of usually 2.5 to 3.5. If you have any more questions, if you're able to, please join the roundtable discussion. We have to close now. But Becs and I are available for questions. If you want to email us, then we're more than happy with that as well.
Thank you. Thanks, everyone.